Good day. I'm happy to have the opportunity to share with you today some information on our assays which can help to manage the current COVID-19 pandemic that we're all living under. My name is Tze Wei, and I'm the Scientific Marketing Manager for Beckman Coulter in Asia Pacific. Today, I'll be talking about our Access SARS-CoV-2 IgG and IgM assays. These are separate serology assays to detect immunity against the SARS-CoV-2 virus, as well as our IL-6, PCT, and high-sensitive troponin I assays. Collectively, these make up a menu panel that matters for COVID-19 management. This is the agenda of the talk today. I'll give a brief overview on the current management and situation for COVID-19, some guidelines and applications of serology in COVID-19 as it currently stands. What is the current role of IL-6 for management of the COVID-19 pandemic in terms of patient prognosis and care, as well as the connection between biomarkers like high-sensitive troponin I or PCT as it relates to the viral and bacterial response in COVID-19 patients. SARS-CoV-2 targets the ACE2 receptors. This is something that we know quite well, and then we know that the virus shares 79% sequence identity with SARS-CoV. As I mentioned earlier, it targets the ACE2 receptors, and this is important because the ACE2 receptors are expressed not only in the lungs, in the alveolar epithelial type 2 cells, they are also expressed in extrapulmonary tissue, for example, the heart, the kidney, intestine, and other organs. This is why in some patients, you do see that in addition to having, respiratory distress symptoms, they also experience multi-organ failure if infection progresses to a more critical state. This is because the ACE2 receptor is also expressed in other tissues outside of the lung. This is a standard chart that shows progression of COVID-19 infection. In the early stages of infection, patient may come in with a dry cough, diarrhea, and headache. You may see lymphopenia, increased thrombin time, increased D-dimer and lactate. And this is the initial viral response phase. In this initial phase, you may see some elevation of IgM as an early serology marker. As the patient progresses into the pulmonary phase, they start to experience shortness of breath and hypoxia. And clinically, you may see abnormal chest imaging or low to normal PCT levels. As the bacterial response phase elevates, in some patients, they may go through a hyperinflammation phase where they experience acute respiratory distress syndrome, ARDS, systemic inflammatory response, SIRS, or shock, or even cardiac failure. And this is where other markers may come into play for patient management, for example, IL-6 or elevated troponin levels. And this is where there is maximal host inflammatory response. Post-infection, usually you can tell when someone has been infected by COVID-19 by the levels of IgG in their blood, and this is seen as a positive IgG. IgM is usually, although it's written here, is usually indicated in the earlier phase of the viral infection. So talking about antibodies, what are the antibodies that we are interested in when it comes to COVID-19 management? We're interested in specific neutralizing antibodies against the S protein or spike protein. And why is this so? So this is the coronavirus with its crown of spike proteins. And it is this spike protein that mediates the entry of the coronavirus into the cell through its binding to the ACE receptors here. And by being able to detect neutralizing antibodies against the spike protein, for example, here, this actually allows us to determine the level of protective immunity in the patient, because the higher levels of these neutralizing antibodies against the spike protein, the more likely it is that this patient has antibodies that are able to block entry of the coronavirus into the cell, meaning that this person is probably protected from future infection by the coronavirus. So this is important to be able to detect antibodies that block the entrance of the coronavirus into the cell. What are the benefits of serology testing? I think holistically speaking, we're looking at a couple of things. We're looking at antibody detection, by looking, for example, at qualitative detection of IgM. We combine with PCR, it does provide a more complete clinical picture. We have heard of some cases of false results with PCR, and having IgM to complement PCR results may help to give a more complete picture. So in the event that PCR is negative but IgM is positive, this may help the healthcare provider to understand whether or not this patient is currently infected with COVID-19. Looking at identifying immune response, so we talked about IgM as a marker of early immune response, but if a patient comes in and they have elevated IgG levels, but no epidemiological evidence, they have not been in contact with anyone previously, and the PCR is negative, it's most likely that they have been infected in the past. So again, it's useful for serosurveillance, and again, we'll talk about that in subsequent slides. In some countries, convalescent plasma is a very hot topic. So convalescent plasma from COVID-19 infected patients are taken out and transfused into other patients as a therapeutic modality. So measuring the IgG levels in these convalescent plasma is important in order to determine the titer of antibodies available in such convalescent plasma that can be used for transfusion. And I mentioned serosurveillance earlier. So COVID-19 prevalence is important as well, identifying how widespread the outbreak is in your country. So serology testing may aid with identifying individuals with immune response to SARS-CoV-2. And as we start to deploy vaccines in countries globally, we may want to also know who is a suitable candidate for vaccine deployment. If they already have SARS-CoV-2 antibodies, and these are protective antibodies, do they need a vaccine? So again, these are conversations that are currently ongoing. I think in a nutshell, serology testing is important for SARS-CoV-2 vaccine development and deployment and the subsequent reopening of society. Because right now we're living in a state of half lockdown, and sometimes we relax a little bit on the lockdown restrictions, but due to an outbreak, the countries may go back into lockdown again. So to have the society fully reopen, it is important to have serology testing complement all the current modalities that we have available for testing under this umbrella of vaccine deployment that we're currently living under. This is an update of WHO's public health surveillance for COVID-19, and this is fairly recent, 16 December 2020. And they talk about serosurveillance studies and its utility in supporting the investigation of an ongoing COVID-19 outbreak. And it's really to support the retrospective assessment of the attack rate or the size of an outbreak. So again, serosurveillance studies are important, and serology assays, specifically IgG, can play a significant role in managing or understanding the extent of a COVID-19 outbreak in a specific population. Earlier on, there were a lot of lateral flow antibody detection assays that were available for use, but currently, as of 16 December last year, the WHO does not recommend lateral flow antibody detection assays for acute diagnosis and clinical management. And even their role in epidemiologic surveys is currently being studied. So what about immune seroconversion, and what does this mean? It's determined by testing for the presence and concentration of antibodies against various SARS-CoV-2 proteins. And the majority of serology assays are either directed against the spike protein or the nucleocapsid protein. And the importance of the spike protein, as I mentioned earlier, is that the spike protein mediates the entry of the coronavirus into the cell. So being able to detect specifically antibodies against these spike proteins helps us to further understand the protective antibody titer in a specific individual, and understand whether or not they truly have protective immunity. And we can measure this in the acute phase in the first few days after onset of symptoms, and again weeks later after symptoms have resolved in the convalescent phase. So a significant rise in antibody titers from baseline to the convalescent phase allows for positive serosurveillance or retrospective case confirmation. I think I mentioned before that although RT-PCR is pretty much the gold standard for a confirmatory diagnosis of COVID-19, RT-PCR results alone have limitations. And this is just one example of a few studies that report a potentially high false negative rate of real-time RT-PCR testing. So RT-PCR results from several tests at different points can vary from the same patient during the course of diagnosis and treatment. And a negative RT-PCR test, whether a patient is symptomatic or not, does not guarantee that they're not infected by the virus as a result. Therefore, having the ability to complement PCR with serology testing using a specific IgG and IgM panel can aid in interpreting and responding to results with greater clinical clarity. So you can see here that in this data, they had 70 patient throat or deep nasal cavity swab samples. And here they saw that 21% of patients, or 15 out of 70 patients, had a positive test result of RT-PCR after 2 consecutive negative results, meaning that the earlier first 2 results were actually false negatives. So what is the guidance from CDC? As of August 1st, 2020, CDC says that serologic testing can be offered as a method to support diagnosis of acute COVID-19 illness for persons who present late, for example, 9 to 14 days after illness onset. And this serology testing can be offered in addition to current viral detection tests, for example, either the PCR or antigen detection test. And SARS-CoV-2 infection can elicit development of IgM and IgG antibodies, and these are the most useful for assessing antibody response because little is known about IgA response. So there's a lot of serology tests in the market that detects a total antibody titer, or they do also look at other antibodies, for example, like IgA. But really, the role of IgA currently in this infection is still unknown. What we do know, like for example, what the CDC says here is that the detection of IgM antibodies may indicate a more recent infection, but the dynamics of the IgM antibody response are not well defined at present. So what is the general viral behavior? Seroconversion for IgM typically takes place early on during an infection, as you can see here. And seroconversion for IgG usually takes place several days after infection, and is the key to long-term immune response. What we do know is that we see IgG elevated for quite some time, a couple of months, even after patients have recovered from the infection, and we do see IgM early on in the early phase of disease. But we also have data to show that these curves are not separate, and in fact, in some patients, these curves, the IgM and IgG curves do rise together. But I think regardless, it is important to have this information because seroconversion is a very individualized process. In some patients, IgM may rise first, followed by IgG, and in some patients, IgM and IgG may rise together. So what is the value of a separate IgM and IgG assays? Because there are a lot of serology assays on the market for SARS-CoV-2. It's either a separate assay or we're looking at lateral flow assays or assays that measure just the total antibody titer. So like I mentioned earlier, in different studies, it has been shown that seroconversion for SARS-CoV-2 IgM or IgG can occur simultaneously or sequentially. So we've seen it rise together, and we've also seen it rise separately as shown here. Regardless of the pattern of immune response behavior, it is really important to identify both IgM and IgG separately, whether or not they're rising together or rising separately. And this is because, in general, IgM will give information about earlier immune response associated with current or recent infection, and IgG is detected later and may indicate a more sustained immune response. So if you're using IgG, if you want to use a serology assay to detect the antibody titer in convalescent plasma, you probably want a separate IgG assay. Or if you are trying to use it to complement PCR testing, as a fail-safe against false PCR results, again, having separate IgG and IgM assays may provide more information instead of just an assay that looks at total antibodies where you wouldn't really know what stage of the infection the patient is at. So this is a snapshot of the clinical sensitivity of our qualitative access SARS-CoV-2 IgG assay. You can see that at 0 to 6 days between positive PCR and sample collection, we have a clinical sensitivity of 70%. And up to more than 18 days between positive PCR and sample collection, we have a clinical sensitivity of 100%. And this data was evaluated in 192 individual patients in a study of 247 serum and plasma samples from symptomatic individuals diagnosed with SARS-CoV-2 using PCR methods. So what can our assay do in a post-infection setting, right? It really integrates high quality antibody testing into a current routine workflow. So this is a chemiluminescent assay on an automated analyzer. It is not a lateral flow assay, so there is high sensitivity, and it can be integrated into the routine lab workflow, regardless of the lab size, to help identify frontline healthcare providers, patients, and community populations who have potentially developed an immune response to the SARS-CoV-2 virus. It detects antibodies to the spike protein, and like I mentioned earlier, the spike protein mediates the entry of the coronavirus into the cell. So this is important for detecting protective immunity based on laboratory studies. The assay runs in random access mode. There's no need for batching. And QC needs to be run only every 24 hours, and calibration is only needed every 28 days. On the DXI 800, the highest throughput analyzer in the market, it can run 200 tests an hour. We see 100% sensitivity at more than 18 days between positive PCR and sample collection, based on a total of 247 samples from 192 individual patients. So we also have data to show that this excess SARS-CoV-2 IgG assay actually detects circulating neutralizing antibodies. And you may recall that earlier on in the talk, I talked about antibodies, neutralizing antibodies that neutralize the entry of the coronavirus into the cell by blocking the interaction of the spike protein with the ACE2 receptor. So we looked at a total of 162 individual patient samples representing 62 SARS-CoV-2 PCR positive samples at more than 20 days after onset of symptoms, and 100 blood donor samples collected before the COVID-19 outbreak. And this was used to evaluate the agreement between the SARS-CoV-2 IgG assay, the one that I just described, as well as a SARS-CoV-2 surrogate viral neutralization test that can detect circulating neutralization antibodies with more than 20% inhibition. So the results we got here were very heartening because we saw 100% negative agreement and 100% positive agreement between our qualitative excess SARS-CoV-2 IgG assay and the surrogate viral neutralization test. So you can be assured that when you are detecting IgG using our excess SARS-CoV-2 assay, you are detecting neutralizing antibodies, because this data here shows that there is 100% positive and negative agreement with the surrogate viral neutralization test. Coming to the IgM assay, this is our qualitative excess SARS-CoV-2 IgM assay, and it's really meant to complement diagnostic testing, RT-PCR, with our current. So it's really meant to be used together as a complement to diagnostic testing, which is usually RT-PCR, which is the gold standard, and is used to support the clinical assessment of COVID-19 patients. So again, the IgM assay targets IgM antibodies against the SARS-CoV-2 spike protein for greater clarity on immune response. And this is again because RT-PCRs are not fail-proof. They do sometimes provide false results. So running this IgM assay together with the RT-PCR assay may provide additional information to help in management of patients in the early days of disease. And what we saw was 98.3 sensitivity, right, and 99.9% specificity validated against 1,400 samples. So we saw 98.3% sensitivity at 15 to 30 days post onset of symptoms, and a total of 173 samples were collected. This is a two-step assay, and results can be obtained in 37 minutes. Similarly, QC only needs to be run every 24 hours, and calibration is only needed every 28 days. So, coming back to the COVID-19 disease progression, accumulating evidence suggests that a subgroup of patients with severe COVID-19 might have a cytokine storm syndrome. And what is cytokine storm syndrome? Cytokine storm syndrome occurs when large number of white blood cells are activated and releases inflammatory cytokines, which in turn activate yet more white blood cells. And this is kind of a classical picture of the cytokine storm syndrome. With the SARS-CoV-2 infection, and as it enters the cell through its interaction of the spike protein and the ACE2 receptor, it activates a variety of white blood cells, for example, your T cells, your macrophages, your neutrophils, results in a large production of cytokines. And with this huge inflammation that is a result of a dysregulated and excessive immune response, this may actually cause immune damage. So we don't really know why in some patients there is a rapid and well-coordinated immune response, which results in a good first-line defense against viral infection. But in some other patients, we see this dysregulated and excessive immune response. It could be due to existing comorbidities, or it could be due to genetic factors. But regardless, with this huge release of cytokines resulting in a cytokine storm and large amounts of pro-inflammatory cytokines like IL-1 and IL-6, this results actually in organ damage as a result of acute respiratory distress syndrome. So IL-6 is an interesting biomarker because it's produced by lymphoid and non-lymphoid cells, and it's an important mediator of fever and of the acute phase response. So, we've talked about serology to kind of help to indicate where the patient is in the cause of disease. But IL-6 kind of has a very different place in disease management. So IL-6, elevated levels of IL-6 actually indicates that this patient is undergoing cytokine storm. And there was actually a paper that suggests that initial evaluation of IL-6 levels should be performed upon hospital admission of COVID-19 patients due to its potential benefits to assess worsening clinical features and disease progression of COVID-19. And in fact, this is because 20% of individuals infected with COVID-19 are sick enough to necessitate hospitalization, and a subset of these patients require intensive care. So, immediate initial evaluation of IL-6 levels, may help in the triaging and management of patients to understand who may need immediate medical attention because of these elevated levels of IL-6, which may indicate a cytokine storm. So just coming back to how IL-6 may help to triage COVID-19 patients. The SARS-CoV-2 is associated with rapid virus replication and a tendency to infect the lower respiratory tract. This can in some patients result in an elevated response of IL-6 induced severe respiratory distress, and serial measurements of circulating IL-6 levels may be important in identifying disease progression among COVID-19 infected patients. But really, what is the connection between IL-6 and COVID-19, and what is the data out there? I think in the past year, we've seen a lot of data to really support this link between COVID-19 and IL-6. So you can see here that there are 4 studies, and in this study, it shows that physicians in Wuhan, China, reported that higher levels of IL-6 were found in the more severe COVID-19 patients. And again, in this study, it showed that IL-6 was higher in those who died than those who survived. So again, IL-6 could be a potential biomarker of mortality. It was also an early indicator of cytokine storm-like condition and analysis by physicians in the Guangdong province of China. And elevated IL-6 was found to be statistically significant predictor of clinical deterioration in Italy as well. So in October last year, we announced that the Beckman Coulter received emergency use authorization for IL-6 assay from the US Food and Drug Administration. So this allows us to use IL-6 to help manage COVID-19 patients by identifying a severe inflammatory response and determining the risk of intubation with mechanical ventilation in COVID-19 patients. And this is important because IL-6 may contribute to the severe inflammatory response, which, as I described earlier, is sometimes also referred to as the cytokine storm. And this was a quote from, one of our chiefs of chemistry at Norton Healthcare. And he said that, his goal is really to keep patients off the ventilator as the best way to help COVID-19 patients. And IL-6 can help to treat the patient before they need a ventilator. So this is a summary or a quick snapshot of what the Access IL-6 assay is about. It's a chemiluminescent assay that can assist in identifying severe inflammatory response in patients with confirmed COVID-19 illness, and it can efficiently and quickly identify associated risk for intubation and mechanical ventilation in COVID-19 patients. Less than 35 minutes time to first result, 28 days calibration over pack stability. And the solution is really that because it allows for identification of severe inflammatory response earlier, and it recognizes associated risk for intubation and mechanical ventilation of COVID-19 patients who access IL-6. This actually allows for more effective assessment and triaging of COVID-19 patients at an earlier time point and can help to better manage both critical patients and valuable resources. So again, this is, the chart that I showed earlier that shows the progression of the COVID-19 infection. And you can see here that, in the early stages of infection, you may see a positive IgG or IgM. And this is the serology assays that I talked about earlier, which can help to support diagnostic testing, for example, as fail-safe to PCR testing. Later on, post-infection, if there's need for convalescent plasma testing or serosurveillance, IgG can also come into play. We talked about IL-6. So actually 80% of COVID-19 patients are asymptomatic, and it's 20% of these patients that may necessitate hospitalization. And a subset of these patients, we don't know why, experience a cytokine storm with COVID-19 infection. And in these patients, they do see an elevation of a variety of inflammatory markers, and more evidence has been published in the past year to show that IL-6 could be a biomarker that indicates this host inflammatory response phase or this hyperinflammation phase that's characterized by cytokine storm, which is why there's a lot of discussion out there on whether or not IL-6 should be used as should be measured initially upon admission to hospital to kind of indicate which are the patients at risk for progression into this host hyperinflammation phase. So kind of switching gears a little bit, that now we talk about procalcitonin and what actually is the connection between PCT and COVID-19. So this is quite interesting because I think in the course of the past year, we have seen that this is a paper from about almost a 1,100 patient data set. And we see that PCT was low in more than 96% of cases with low disease severity and no adverse outcome. However, in patients who had PCT of more than 0.5 micrograms per liter, and this is a clinical cutoff point, this corresponds to almost a 5 times higher risk of severe infection compared to COVID-19 patients with lower PCT. And again, PCT could be a potential biomarker to suggest who are the patients that may progress in a more who may have a more negative prognosis as compared to patients who have low levels of PCT, which would be less than 0.5 micrograms per liter. And these are the patients who would have an absence of adverse outcome. So the IFCC does give us a very strong suggestion to test PCT in severe COVID-19 patients for early identification and treatment of bacterial co-infections in such complex medical conditions. So our excess PCT assay actually correlates with the severity of bacterial infections and the probability of a positive blood culture. And this is because there's a subset of patients in COVID-19 patients who may be at risk of sepsis, and physicians need a fast and efficient way to identify patients at increased risk for sepsis. So some aspects of our PCT assay is a random access, and it's a 20% CV LOQ of 0.02 nanograms per mil and a less than 8% CV at concentrations of 0.5 nanograms per mil. Time to first result is 20 minutes. Calibration and open pack stability is 28 days. So generally, PCT is a useful diagnostic tool to assess patients with suspected sepsis or life-threatening septic shock. And for that subset of COVID-19 patients who may progress to sepsis, again, PCT is a useful biomarker for the management of these patients. What about troponin I? I mentioned troponin I very early on, and I think one of the things that we're learning about COVID-19 is that ACE2 receptors, through which the coronavirus enters, is expressed on extrapulmonary tissue, for example, like the heart. And because of this, we do see a proportion of COVID-19 patients, about 12 to 28%, presenting with elevated cardiac troponin levels. And elevated troponin has been shown to correlate with increased likelihood of need for ICU care. And cardiac injury was seen in 1 in 5 patients as an independent predictor of dying. Mortality was 10-fold higher in those with cardiac injury on presentation. So again, for a certain subset of patients where there is a more negative prognosis with their COVID-19 infection, other biomarkers such as IL-6, or PCT or high-sensitive troponin I may be very effective in helping to manage such patients, helping to identify whether or not they may progress into a more critical state. So this again is a snapshot of our excess high-sensitive troponin I assay. It offers excellent precision at very low levels of troponin, which may help physicians to interpret small changes in low levels of troponin over shorter periods of time, helping them to assess whether or not further intervention is needed at an earlier time point. What we see here is that there's high precision. The assay in precision is 3.4% at 18 nanograms per liter, which is our cutoff point, and accurately identifies more than 94% of acute myocardial infarction patients in as little as 1 hour after presentation. So, I talked a lot about the different assays that we have that make up this COVID-19 panel, which comes down to a menu panel that matters for COVID-19. So I think what is really important is the serology assays. We have the IgG assay, and I've discussed that we have 100% sensitivity for our qualitative IgG assay at 18 days post-PCR positivity, highest in the market sensitivity of 70% at 0 to 6 days post-PCR positivity. And this was derived from 247 samples from 192 subjects, almost 100% sensitivity from almost 1,400 samples, and 28 days onboard stability with calibration required every 28 days. One thing that I forgot to mention earlier was that this assay actually has an equivocal zone. So there's a non-reactive reading, which means that no antibodies were detected. And there's reactive, which means that positive reading, right? IgG antibodies were detected. But there's also an equivocal zone because seroconversion is an individualized process. So if the patient comes up with equivocal reading, this means that it's inconclusive. The patient may still be in a process of seroconversion, and it is recommended to retest in 1 to 2 weeks. So its intended use here for this IgG assay is really as an aid in identifying patients with adaptive immune response to SARS-CoV-2, and this can indicate a recent or prior infection. So depending on your use case scenario, whether it is for testing of convalescent plasma or for serosurveillance or monitoring of disease progression, it can be all used to identify the immune response in these patients. And I've shared earlier that the IgG has 100% negative and positive agreement with surrogate viral neutralization assay. This means that IgG that is detected by this qualitative assay, it does detect the protective neutralizing antibodies to excess SARS-CoV-2. For excess SARS-CoV-2 IgM assay, again, there is 98.3% sensitivity at 15 to 30 days post-symptom onset, and almost 100% sensitivity with 1,400 samples. And similarly, 28-day onboard stability and the 28-day calibration. It is also used as an aid in identifying patients with adaptive immune response to SARS-CoV-2, indicating recent or prior infection. And its use case scenario is really to complement diagnostic testing, which is RT-PCR, for confident clinical assessment during early infection. So that was the serology panel. And, to fully make up a menu that matters for COVID-19, we also looked at a variety of other biomarkers. And this is because in various stages of infection, COVID-19 patients may experience cytokine storm syndromes, sepsis, and cardiac events. So serial measurement of circulating IL-6 levels and measurement of PCT and troponin may be important in identifying the disease progression among COVID-19 infected patients to know who may have a more negative prognosis before it actually happens. And in fact, an increasing number of publications in the past year actually suggests that elevation of IL-6 is associated with the severity and more negative clinical outcomes of patients with COVID-19. And a SARS-CoV-2 infection, as we know, may result in elevated response of IL-6-induced severe respiratory distress. So collectively, the serology and the biomarker panels, for example, the IL-6 or PCT or troponin I, will help to manage patients, as we live under this current COVID-19 pandemic. So I think with that, that is my last slide. I thank you for attention today, and I'll be happy to take any questions. Good day. My name is Tze Wei, and I'm the Scientific Marketing Manager for Beckman Coulter in Asia Pacific. I'm very happy to have the opportunity today to share with you some information on our new hematology parameter monocyte distribution width for improved sepsis detection in the emergency department. This is the agenda of my talk today. I'll talk a little bit about the epidemiology and some guidelines of sepsis, the clinical unmet need for sepsis detection, especially in the emergency department, how our hematology parameter monocyte distribution width can help to address some of the unmet needs surrounding early sepsis detection, followed by some concluding remarks. This is a picture kind of depicting the worldwide problem that sepsis poses, and the incidence of sepsis is rather consistent between different countries, somewhere between 300 and 500 annual cases for every 100,000 persons, or 0.3 to 0.5% of the population annually. The mortality and cost of sepsis cases vary widely, both based on the severity of the presentation and frankly on the availability of the healthcare resources to confront it. It is very telling that in certain countries where resources may be more limited, like Brazil, which still has sophistication of conducting broad epidemiologic research, there is an acknowledgement that sepsis carries extremely high mortality. In US, the variance in sepsis cause and mortality also clearly relates to the severity of presentation and syndrome progression. I think overall you can see that while mortality can vary widely depending on resources of the country in question, it is commonly acknowledged that there is a specific high cost associated with every case of sepsis. So this is a study that looked at the causes and outcomes of sepsis in Southeast Asia. And you can see here that for all of the non-survivors, 90% of them were actually suffering from severe sepsis. And the authors concluded that there was a need for rapid, inexpensive, and accurate multi-disease diagnostic tests, especially in tropical developing countries. The most recent update to the sepsis guidelines is basically the third international consensus definitions for sepsis and septic shock, or sepsis 3. And sepsis 3 really looks at defining sepsis as organ dysfunction. And you can see, it uses this SOFA scoring system, or sequential sepsis-related organ failure assessment score, which looks at the functions of different organ systems ranging from respiration, coagulation, liver, cardiovascular, central nervous system to renal. And in the emergency department, physicians often use a quick SOFA scoring criteria that looks at just 3 parameters: respiratory rate, altered mentation, and systolic blood pressure. So that was the sepsis 3 guidelines that was developed in 2016. But what about the sepsis 2 guidelines that was in use before that? So what has changed between sepsis 2 and sepsis 3? So the old sepsis 2 guidelines were developed in 1992. And the main change that you see here is that what was previously defined as severe sepsis is now just defined as sepsis. So this really kind of, realigns and narrows down the definition of sepsis a little bit to make sure that when you say a patient is having sepsis, the patient is really suffering from a life-threatening organ dysfunction that is caused by a dysregulated host response to infection. So here is another way of looking at the differences in sepsis 2 and sepsis 3 guidelines. So previously, what would have been defined as sepsis under the sepsis 2 guidelines, today under the sepsis 3 guideline is defined as infection with ICU stay. And in fact, the patient must exhibit some evidence of organ dysfunction due to infection in order to be classified as septic as per the sepsis 3 guidelines, whereas this previously would have been defined as severe sepsis. So you can see here that in this previous slide, what was defined as severe sepsis is now considered as sepsis in sepsis 3. So here, so what was severe sepsis in sepsis 2 guidelines is now sepsis in sepsis 3 guidelines. So septic shock definition still remains unchanged. What this means in terms of treatment bundles is that initiation of treatment bundles occurs at this point when patient is showing some evidence of organ dysfunction due to infection. However, we have learned that sometimes to initiate treatment at this point may be too late for some patients. Ideally, it is best to initiate right treatment to the right patient as early as possible. So let's look at the current state of emergency department sepsis assessment. So previously, under the sepsis 2 guidelines, physicians were using the systemic inflammatory response syndrome, or SIRS, and they looked at a variety of parameters, including ranging from temperature, heart rate, respiratory rate, white cell count, blood glucose, and a new altered mental state. For the sepsis 3 guidelines, they're really looking at organ failure. So for example, if they're using a quick SOFA score, they would only be really looking at respiratory rate, systolic blood pressure, and altered Glasgow Coma Scale, which also looks at the mental status. So regardless of whether it is the sepsis 3 guidelines or the sepsis 2 guidelines, I think the clinical challenges of sepsis remain unchanged in that really sepsis diagnosis, especially in the emergency department, can be highly subjective. This could be due to insufficient sensitivity and specificity of tests and risk scores. And also it's not helped by the fact that in about 30% of patients presenting to the emergency department, they actually display ambiguous symptoms. And as a result of these ambiguous presentations, some of these patients may take a longer time to get antibiotics, resulting in eventual higher in-hospital mortality. And it's because of this challenge of diagnosing sepsis early that some patients do not get proper disposition in the ER, and we do see high mortality in patients discharged to the general ward or home compared to those in the ICU. In addition, really, I think adherence to guidelines remains inconsistent globally. So the sepsis bundle compliance was indicated in the surviving sepsis guidelines. However, this compliance to this sepsis bundle treatment is only about 50% in the US, and it's actually even lower in resource-constrained environments. So what we do know is that delay in antibiotic administration leads to higher mortality. But this is quite critical because this is juxtaposed against an environment of very strict antimicrobial stewardship. So in reality, what physicians really want to do is to try to give the right antibiotics to the right patient at the right time to prevent a rise in antimicrobial resistance and yet still treat the patient and detect sepsis early on. So this is a paper that actually looks at the timing of early antibiotics and hospital mortality in sepsis. And I think it really underscores the point I was trying to make earlier, where it shows that for every elapsed hour between antibiotic presentation, between patient presentation and antibiotic administration, it was associated with a 9% increase in the odds of mortality. And the authors do conclude that, antibiotics given within the first hour of registration were really associated with the greatest benefit. So with this problem, this clinical challenge that we're aware of, we really wanted to be able to develop a marker that would allow physicians to detect sepsis earlier and allow them to know sooner. So just taking a step back and maybe taking a very high-level overview of the current sepsis screening tools, the ideal test is really a test that is very sensitive, very specific, routinely performed on most ED patients, emergency department patients, and of course it should be cheap. However, there's no such thing as perfect or ideal in this world, but let's take a look at some of the tools available. So white blood cell count, for example, can be quite sensitive, but it's not very specific because there are many conditions where white cell count is elevated, but it's not sepsis. However, it is routinely performed on most ED patients and it is relatively cheap. Procalcitonin and tissue cultures can be quite specific, but sensitivity is not really there. And in addition, these are tests that are not routinely performed on most emergency department patients, and they can be quite expensive. And I think it's because of this clinical unmet need that over the last decade, several sepsis biomarkers were proposed. And in fact, this review actually highlights, that there were about 178 biomarkers developed and discussed over more than 3,000 articles, and it actually spans different clinical applications, including diagnostics, discrimination from SIRS, the systemic inflammatory response syndrome, as well as prognostics. So at Beckman Coulter, we developed a hematological parameter, monocyte distribution width, for discrimination of sepsis in the emergency department. And actually many physicians and customers have also asked us, why monocytes? Why did you just pick monocytes? So in one of our pilot studies, we actually studied the neutrophil as well. But what we found was that, in comparison to the monocyte, the monocyte distribution width actually best discriminates sepsis, for example, as compared with neutrophil volume changes from other acute illnesses in the emergency department. So again, monocyte as a member of the innate immune defense system was able to, show potential signs of a patient developing sepsis by detecting the volumetric changes of the monocyte. And this is because the monocyte is part of the innate immune defense system, which is the first line of defense against any infection. So this was the pilot study that looked at improved early detection of sepsis in emergency department with a novel monocyte distribution with biomarker, and I'll show you some data from that in the subsequent slides. But after this pilot study in 2017, we then went on to do a full-scale clinical trial, and this was published in August 2019, that also looked at the performance of monocyte distribution width as a novel indicator of sepsis 2 and 3 in high-risk emergency department patients. So this clinical trial was actually a blinded prospective observational study conducted across 3 sites in the US with more than 2,000 consecutive adult emergency department patients. So inclusion criteria was they were all adults, they had to have a CBC with differential audit, and the patient remains in the hospital for a minimum of 12 hours. And sepsis prevalence was defined by the sepsis 2 criteria, as defined by the sepsis 2 criteria, was 17.8%. So in this entire population, they had 385 septic patients. So in order to characterize sepsis as being present upon ED admission, sepsis criteria had to be fulfilled within 12 hours of the initial CBC in patients with suspected infection. And infection was determined based on retrospective chart review of tests performed and clinical data available within the first 12 hours of emergency department presentation. If no workup for infection was initiated within 12 hours, the patient was then classified as not infected. So in this pivotal clinical trial, the primary endpoint was really to determine whether MDW above the cutoff of 20 units Okay, and this was actually based on the earlier pilot study done in 2017. So it was the primary endpoint was to determine whether MDW above the cutoff of 20 alone or in combination with white blood cell count can improve early sepsis detection by sepsis 2 criteria. But knowing that the sepsis 3 guidelines were just developed, we also had a secondary endpoint that determined the MDW performance for sepsis 3 detection. So coming back to MDW, what exactly is monocyte distribution width? It looks at the volumetric changes of the monocyte as a member of the innate immune defense system as it responds to an incoming infection, a pathogen or infection. So what we'll see is that there is variability and it changes in shape and size as it's changing and responding to an infection and resulting in cytokine secretion and recruitment of other white blood cells. So this change in volumetric morphology and size is actually reflected as a change in monocyte volume here on the scatter plot of the hematology analyzer. So with activation of the MDW parameter on our hematology analyzer, the monocytes, which are the green cells here, actually get measured on an extended volume, EV, extended volume range. So what this does is that it allows for more accurate measurement of this change in volume of monocytes, whereas in the past, if it weren't measured on the extended volume range, the monocytes all have been clustered here. So you may get an increased monocyte distribution with reading, but this reading would not have been accurate because of this cluster of cells here. So activation of the monocyte distribution width parameter, allowing for a greater greater measurement, more accurate measurement on a bigger scale, would allow for more accurate measurement of this change in monocyte variability. So this was actually from the initial pilot study conducted in 2017. And if you may recall, I mentioned earlier that we also looked at other volumetric changes of other immune cell types. And specifically, we looked at changes in the neutrophils. So what we saw was that MDW, or monocyte distribution width, best discriminated sepsis from other acute illnesses in the emergency department as compared to the mean neutrophil volume or neutrophil distribution width. You can see that MDW, or monocyte distribution width, actually had the best combination of area under the curve, sensitivity, and specificity as compared to mean neutrophil volume and neutrophil distribution width over here. And what we saw was that the clinical performance of monocyte distribution width together with white blood cell count for early sepsis detection was superior to either monocyte distribution width or white blood cell count alone. And this we looked at the ROC, AUC values. So when discriminating between sepsis versus all comers to the emergency department, or sepsis versus serious patients with systemic inflammatory response syndrome, but they were not classified as sepsis, you can see that when combining the white blood cell count and monocyte distribution width, these two parameters, when combined together, always gave the best ROC AUC curve as compared to white blood cell count or monocyte distribution width alone. So what about the pivotal trial that was published in August 2019? How did monocyte distribution width perform in that larger population? So you can see here that the monocyte distribution with a cutoff at 20 had sensitivity and specificity, a sense of 74% and 72% respectively. And more importantly, the negative predictive ratio was 93%. What happens when we add MDW to white blood cell count? We've shown that there's an increase. It has the highest ROC AUC values. But what does this mean clinically? What is the probability of patients developing sepsis when they come in with an abnormal MDW and abnormal white blood cell count? So here we define abnormal white blood cell count as more than 12 or less than 4, so too high or too low. And you can see here that when patients have an abnormal MDW as defined as above 20, or an abnormal and an abnormal white blood cell count, you can see that probability of patients developing sepsis is about 64%. And this is set against a backdrop of about 18% prevalence of sepsis in the clinical population. On the flip side, if the patient comes in with a normal MDW and a normal white blood cell count here, so normal MDW is defined as a cutoff of less than 20, and a normal white blood cell count is defined as between 4 and 12. And what you see here is that the probability of the patients developing sepsis actually drops all the way down to less than 3%. So the availability of monocyte distribution width as an additional parameter to actually helps to modulate the probability of patient developing sepsis either upwards or downwards, depending on whether or not MDW is above the cutoff, meaning it's an abnormal MDW result, or if it's below cutoff, meaning it's a normal MDW result. So here, another way of looking at the clinical trial data, you can see that when MDW is above the cutoff, combined with a normal white blood cell count, this further increases the suspicion of sepsis to 64%. But if the patient has a normal MDW below the cutoff of 20 and a normal white blood cell count, again, it modulates the probability of sepsis all the way downwards to less than 3%. So just to summarize what we have learned in the pivotal clinical trial, we know that the CBC differential is routinely obtained in most patients presenting to the emergency department. White blood cell count is the current lab standard for initial detection of severe infections. It is very sensitive for sepsis detection, but it's not specific because there are many conditions that result in an elevated white cell count. So MDW can enhance the performance of white blood cell count for early sepsis detection, as you can see with the differences in ROC AUC values, and we also looked at some of the probability and likelihood ratios through statistical added value analysis. Because MDW can be automatically reported with complete blood count and differential as a means of sepsis detection during the initial emergency encounter, is actually a very useful information to add on to the current clinical practice because it helps to modulate the probability of sepsis either upwards or downwards, depending on whether it's abnormal or normal. And this is quite unlike current sepsis biomarkers, which are typically used as confirmation after the initial patient encounter in the emergency department. For example, if you're looking at procalcitonin or lactate, these are markers that usually order after patient has been admitted, or there's a clear suspicion that these patients could be developing sepsis. Whereas MDW is ordered much earlier on in the patient care pathway where the CBC and differential are ordered. So again, this is additional information that may help in detecting sepsis earlier. So this is a case study of a patient without sepsis. You can see that this patient came in for initial diagnosis of Crohn's disease, IBS, GERD, anemia. With the Crohn's disease, there's a bit of inflammation going on. However, you can see that MDW is below the cutoff at 17. This is a patient that came in with initial diagnosis of pneumonia. She was actually eventually given levofloxacin, and her final diagnosis at 7 hours after receiving the complete blood count differential was sepsis as a result of sears and infection. And in fact, her MBW was high. It was about 28%. And you can see that these monocytes are kind of stretched out, indicating that there are some volumetric changes. So I've talked about, modulating the probability of sepsis with MDW, and I would like to spend a little bit more time to elaborate on this. So MDW is really not a definitive rule-in or rule-out marker, right? But because it is available very early on in the patient care pathway, it helps a physician to increase his index of suspicion of sepsis. And this is especially helpful when a septic patient or potentially septic patient presents with ambiguous symptoms, for example, few SIRS criteria, for example, 1 or 2 CS criteria at hospital using the sepsis 2 definition, or on the chart on the right, when he comes in with a very low Q-SOFA score using the sepsis 3 definition. And if you look at both charts, they tell the same story. So the x-axis here is the number of positive CS criteria, and there's a total of 4 CS criteria for those being abnormal white count, abnormal temperature, abnormal elevated heart rate, and elevated respiratory rate. The y-axis is the probability of the patient actually being septic. So, just to remind everyone, the clinical role of MDW is really to increase or decrease the index of suspicion of sepsis based on either a higher or lower probability of sepsis. So again, it's about modulating its probability. So let's look at the chart here on the left, which is the sepsis 2 definition utilizing sears. As a clinical example, a patient presenting with just 1 positive sears criteria may be a challenge to recognize sepsis. So the blue bar at 1 sears criteria here represents a normal MDW alongside the presence of 1 positive sears criteria, which is a very low probability of sepsis. However, when the presence of just 1 sears is accompanied by a positive or abnormal MDW, which is this purple bar, the probability of sepsis becomes 3.9 times higher, almost 4 times higher, again giving the physician a warning or higher alert for sepsis in this patient who presents initially with just 1 sears, which may be a very vague symptom. And looking at the other purple bars to the right, the more sears that are present coupled with an abnormal MDW, you can see that from the blue bar to the purple bar, there is an increase in the probability of sepsis. And the gray bar is Sears only if there is no MDW result. So you can see here that if you only have a Sears score, having a normal MDW would then modulate the probability of sepsis downwards. And having an abnormal MDW would then modulate the probability of sepsis upwards. And the same clinical interpretation holds true in the chart on the right for hospitals that are using SOFA scoring as per the sepsis 3 guidelines. Again, the higher the SOFA score, when coupled with an abnormal MDW, the higher the probability of sepsis. So coming back to the intended use for MDW. MDW is an FDA cleared and CE marked hematology parameter. And while there are many hematology parameters out there that have been shown in literature to be, that could be used to help detect changes in the white cells, suggesting possible changes in infection status of the patient or sepsis, but MDW or monocyte distribution width is the only FDA cleared and CE marked hematology parameter that is intended for use with adult patients presenting to emergency department on whom a white cell differential test has been ordered as an aid in the early detection of patients with or developing sepsis. So this is the only hematological parameter out there that has been cleared by regulatory agencies for such a specific usage. So MDW, together with other laboratory findings and clinical information, would provide a qualitative assessment of sepsis from a whole blood venous sample. So one of the very clear ways of using MDW would be together with either the Sears scoring or the SOFA scoring. And here I've shown you the clinical data to show that MDW can modulate the probability of sepsis either way, downwards if it's normal, upwards if it's abnormal. So MDW values above 20 should really raise this level of suspicion that adult patients have or will develop sepsis within 12 hours to the emergency department. And this is a typical care pathway with monocyte distribution width and using MDW as an early sepsis indicator. So patient comes in and initial triage may indicate possible infection in the emergency department. A CBC differential is ordered, and MDW is available on the initial CBC diff result, whereas CBC is ordered as part of the routine labs. So again, a normal MDW result will modulate the probability of sepsis downwards. An abnormal MDW result may modulate the probabilities of sepsis upwards, and this is together with clinical signs and symptoms, whether the physician is using Sears or SOFA scoring in their healthcare institution. And with this, combined with these two sets of information, patients may need to have sepsis evaluation tests ordered, for example, lactate, procalcitonin, CRP, or IL-6, depending on what is the sepsis protocol at the institution. So you can see that MDW does complement the sepsis care pathway, but at a very much earlier stage when they first come in the emergency department, and is quite separate from the standard panel of sepsis confirmatory tests. So just to kind of conclude some of the information that I've shared so far, sepsis is a high healthcare burden disease. Early diagnosis and treatment intervention really reduces sepsis-specific mortality, and it is a complex inflammatory syndrome that is challenging for many biomarker validation. And I've shown how monocyte distribution width from our DXH900 hematology analyzer may actually play a possible role for early diagnosis of sepsis due to its availability with every complete blood count with differential. Ideally, it should be used with the existing sepsis protocol in the institution, whether it is sepsis 2 guidelines using the Sears scoring system or sepsis 3 guidelines using the SOFA scoring system. As you can see, having that abnormal MDW would then modulate the probability of sepsis upwards, and a normal MDW would then modulate the probability of sepsis downwards when used in combination with such scoring protocols. And in fact, combining the scoring systems with biomarkers would really result in optimal benefit to the patient. So I've talked quite a bit about the clinical information and data surrounding monocyte distribution width as an early sepsis indicator, but I want to spend a few of the next few slides, a bit of my time really to kind of talk about the DXH900 hematology analyzer as well, because it is on this analyzer where the monocyte distribution width can be found. Is available as a parameter that can aid in early sepsis detection. So this is a picture of the DXH900 hematology analyzer. It's a standardized look and feel across our product family. There is an integrated user interface, and this entire integrated workstation really allows for a small footprint. So it allows for increased lab flexibility. There's a wireless mouse and keyboard. And you can see that the computer and scanner are also located inside the cabinet. So overall, we see that because of the small footprint, there's actually a lesser lab space requirement, up to 45% less than the DXH 800 solution. So we have seen that on DXH 900 hematology analyzer, there are less flex, less repeats, and because of the smaller footprint, it uses less space. We do see that it is one of the highest productivity work cells on the market. And the DXH 900 really, with its small footprint and maximum uptime, can deliver more clinical value with a single analysis, allowing for more reportable results and a reduced total cost of ownership. So what is the technology behind DXH 900? The DXH 900 proprietary technology actually has three key aspects. It actually has three key aspects are the enhanced Coulter principle. It gives better CVs compared to competitors due to triplicate counting with sophisticated bolting, extended counting, and sweep flow ensures that every cell is counted singly. There's BCS 360 that looks at 5 angles of light scatter combined with volume conductivity for accurate differentials, and 4 measurements of every files to qualify its characteristics. So the VCS 360 really measures cellular electro-optical properties to provide morphometric parameters. And there's also the data fusion technology, which looks at the inter and intra-modular comparative analysis. And this really eliminates the need for reruns because data fusion actually increases confidence in results and improves overall flagging. So when we talked about sweep flow earlier as part of the DXH 900 proprietary technology, we mentioned about how this technology enables us to obtain an accurate electrical pulse signal. So for every single cell, we take the pulse signal it has produced and we carry out 7 individual measurements on that pulse signal to allow us to accurately calculate the right result. So with this sweep flow and these measurements also allow us to identify what is a cell, what is not a cell, if 2 cells have gone through the aperture at the same time, and also if there are any fragments. So this then allows us to accept the cells and use the data in the calculations or discard the data so that it does not wrongly influence the overall results. Just to give you a quick overview on some of the differentials that are available and the technology behind it, the DXH 900 technology analyzes cells in their near native state. So no stains, no added solutions or fixatives to the cells. We analyze the cells as they are beyond what a microscope can see because there are really no stains added to it. So as they're really as close to the environment in the human body as possible. There is extended counting time for samples with low white blood cell count in leukopenic samples, for example, with patients who are on chemotherapy, and this produces reportable results after the first run for every sample without the need for additional modes. There's a count extension up to 50,000 cells per sample, and this helps to produce a reportable white blood cell differential for samples with lyse resistance RBCs. And samples with R flags on impedance white blood cell count could always have optical white blood cell count as estimation of final white blood cell count. However, this is really an RUO parameter only. So for high white blood cell count samples, for example, leukocytosis, in cases of leukocytosis, the DXH 900 autocorrects all results and eliminates interferences, and these are the parameters that it corrects. I also want to touch a little bit on the platelet technology. So we do see accurate platelet results for every sample without the need for extra runs, extra stays, extra reagents, and extra cost. We have seen excellent agreement with the flow reference method, which is looking at the CD41 and CD61 markers for platelet identification. There is better precision as evidenced by lower coefficient of variation compared to other instruments, and there's a low background of 3,000 cells per MCL. So overall, we do see efficient platelet flagging as a result of the data fusion technology that I mentioned earlier and intermodule intelligence, and you get an MPV with every CBC differential count. So in summary, the DXH 900 technology, overall the DXH technology really provides high first pass yield, 93% first pass yield for increased productivity and savings. So this 93% first pass yield is seen in our internal evaluation and has been corroborated at customer sites evaluations globally as well. So overall, this machine has performed very well in terms of first pass results. And this is due to the powerful advanced analytical process that analyzes cellular data from every functional module within the system to provide lower review rates. And this is an added benefit is that the cells are also analyzed in their near native state. There are no stains added on that may change the morphology of the cells. The cells are analyzed as close to the environment in the human body as far as possible. So I've talked about the clinical data surrounding monocyte distribution width and how it can be used as an aid in early sepsis detection emergency department. But I also shared with you some of the technology behind our DXH900 hematology analyzer that provides monocyte distribution width as a parameter. So with that, I will end my talk today, and thank you for your time and attention. Thank you very much.